Human Services Committee to order, and we have two bills today, and thank you everyone from Finance who is getting here. We much appreciate the Finance Chairman adjourning the meeting just for HHS. All righty, thank you. With that, Chairman Brass, do you mind saying a little prayer for us, please, sir?
Please bow your heads with me. Dear Lord, thank you for this day. Thank you for all that you do for us. Thank you for sending your Son, Jesus Christ, down the cross for our sins. And we're sorry there are many. Amen.
Yeah.
Speak for yourself.
Holy breath.
You speak for yourself.
Sydney, is there any way we can edit that? We're good. All right, that is ever so true. There are many. So, all right, SB 440, Senator K. Kirkpatrick. You can stay in your seat to go around, whatever you'd like to do. All righty. And then next up is Senate Bill 462. If we can get those sign-up sheets. Everybody signed up that wants to be. And so that's good. So witness 1, witness 2. All righty. So they're both on.
Thank you,
The floor
Mr.
is yours.
Chair. I brought a friend with me, Megan Andrews from the Department of Public Health, because she has even deeper knowledge of this bill than I do. And so it's complicated, and you can tell that because I have all these sticky notes on my bill. And but it's really simple. It's simple and complicated at the same time, because what it is, this is an agency bill for DPH. It's a cleanup bill, and it does not affect any programs. It does not get rid of programs that are currently operating, and it just removes obsolete and unused code sections and updates the statute. So right now, DPH technically is out of compliance with multiple code sections tied to things that don't really exist. And so if we clean this up, it'll improve transparency and reduce confusion about their responsibilities and free up staff time from fulfilling mandates that really don't make any sense. So there are several major categories in here that I'll go through. And we can ask Ms. Andrews for additional detail on any specific ones. But the first thing I'm going to talk about is there are outdated marriage-related health requirements. We have brochures that we really don't do paper brochures too much anymore about HIV, listing test sites and things like that. That language was written in the 80s and is not really relevant anymore. Sickle cell testing, another brochure that is being handled in a more modern way now. And then also DPH has a marriage manual requirement, and that one was written in 1973. So these materials are not how we educate Georgians about these things today. Then also there are some dormant boards, commissions, and positions that are covered in the bill. The PDMP you're very familiar with, and that's operational and has been for years. And there used to be an advisory committee which was put together at the startup of the PDMP.
Prescription drug monitoring program.
Yeah, it's where physicians record the prescriptions, and they can search the database to see if someone's doctor shopping or whatever. But that has been operational for, I don't know how many years, but a long time.
Over 10, maybe came in about 15 years ago. Came in, if I remember correctly, Buddy Carter carried it, and it's been Georgia's been one of the first ones to do it. We do cooperate with other states, so it markedly reduced the doctor shopping for opioids, and that's been a tremendous help. ER-wise and primary care, and listen, pain management too. So I can talk for a while on that.
So it's, anyway, that program is working well, and we don't need that startup advisory committee anymore. There also was a cancer advisory committee and a cancer control officer that was put in code in the 80s, but that committee does not exist, and that position has been vacant for years. There's also a commission for saving the cure, which has to do with cord blood. No appointments have been made to that since 2008. And this bill keeps Georgia's ability to have postnatal tissue and fluid banks, but it does not require DPH to oversee a commission that does not exist. There are some existing taxpayer-donated funds, because this is a checkoff, that are going to be addressed between DPH and the Office of Planning and Budget in the budget process. There are unfunded or non-operational chronic disease programs. Two are osteoporosis and arthritis programs. They were established in statute but never funded or implemented. There's also a section of the bill that aligns statutes with current operations. So in other words, blindness, education, screening, and treatment is reassigned to the Georgia Vocational Rehab Agency, which is more appropriate to handle that program. There's a home visiting pilot. The pilot phase is over. Home visiting is now a permanent DCH service, and the statute's updated to remove that obsolete pilot language. There's a newborn hearing screening, and the screening and reporting are intact in the bill, but there's an advisory committee that's already been eliminated, and so this just cleans up Scrivener's error in the bill. Neonatal abstinence syndrome. DPH has an annual report requirement, but they really don't have the in-house experts to do an annual report. They do get information reported to them about neonatal abstinence syndrome, but the agency that deals more with substance use and things like that is DBHDD. And then there's some unfunded mandates and other requirements. For example, EpiPens. There's a requirement in statute that every administration of EpiPen be reported to DPH and compiled into an annual report, which clearly is not normally reported to DPH. Stroke centers and emergency cardiac care center grants. These grant programs are still on the books, but the annual reporting requirement will be subject to appropriations in the bill. And this keeps DPH from having to file zero activity reports in years when no grant funds are appropriated. There's a Georgia Volunteer Healthcare Program report, and the bill modernizes the required report to focus on utilization and access and updates the committee names to match the current House and Senate committee structure. So that's sort of a brief summary. We can go into more detail on anything that is of interest to the committee, but the important point is that no Georgians lose services as a result of this bill. The bill does not shut down any active programs. And in summary, this bill cleans up outdated and unused sections of the Georgia Code, aligns the statute with current DPH programs and partnerships, and reduces unfunded mandates without affecting services. Thank you.
Thank you so much. Ms. Andrews, you have anything to add?
Nope, I'm here for questions if there are
Great.
any.
Any questions from the committee? All right. Over here first. Senator Merritt, you are on number 10. Okay.
Mr. Chairman, so why remove the AIDS requirement and the sickle cell requirements?
So right now that information is posted and shared on our website. These brochures were required back before internet websites were readily accessible. So that's how we share information now, as opposed to handing out brochures in probate courts when people are applying for their marriage license.
For a marriage license, I got you.
It's for marriage license
Yeah.
applicants are required to receive these brochures.
Okay.
Yes.
Senator Huffstetler, number 11.
All right. Great to have Miss Andrews here, our intern from a decade or so ago. Still looks as young. But I was just thinking that 1973 marriage manual, if it had been read by Senator Robertson, maybe he wouldn't have entered into all those marriages he's entered into. So.
Okay, all right, Senator Brass, with a serious question, I hope. Here we go.
I doubt it.
My serious questions first. All right, on line 247, we're striking President of the Senate and putting Lieutenant Governor. What if we don't have a Lieutenant Governor, but we have a President of the Senate? This is the question. If the Governor dies, the Lieutenant Governor goes to Governor. The President Pro Tem becomes the President of the Senate, but he's not the Lieutenant Governor.
I would actually ask Legislative Council to help with that because they, in drafting, this was language they added.
So the President Pro Tem would go to President, and you're saying there would be
But
no
I don't
Lieutenant
think,
Governor?
and there is debate over that, but
And there'd
I
be-
feel like there may not be, we may be solving the debate with this, and I don't know that
Yeah,
this is the
I
right
get it. I get it.
avenue
I
to
don't know.
solve that debate.
What do you, all right.
We usually use the different title for the different role. It's the legislative role versus the executive role. It's how our office is listed.
So, okay.
Could you repeat what she said? She didn't
So
have-
she said we usually use executive versus legislative titles. Instead of Lieutenant Governor, you'd use President of the Senate. And President Pro Tem would be President of the Senate if, at that point. That's why they, President Pro Tem.
So if the Lieutenant Governor passed away or the Lieutenant Governor was appointed to Governor, then you just wouldn't send it to the Senate.
It would go to the President.
No, there wouldn't be a Lieutenant Governor to send it to.
It still
Oh, you
goes-
changed it to Lieutenant Governor.
Right.
Oh, yeah.
And it
Okay.
still goes to the chair of the health committees.
There
on
you
both
go.
sides.
That's all you need, really.
Okay, I was just curious on that. And then, I guess this next question, on all of these reporting, we're adding subject to appropriations. Is that subject to additional appropriations, or?
Neither one of these grant programs have ever been funded.
Okay.
So right now, we're required to submit annual reports, but there is nothing to report.
Okay, I got you. And then I guess my final question, I saw we were eliminating the cancer control officer. Have they been notified?
That position is vacant and has been vacant for, gosh, I would have to call on Senator Orrock. How long ago was Dr. Toomey the state health officer? I think in the 90s. Yeah.
This is cancer control
Yes,
officer.
I'm saying back in the 90s when she was here, then
Uh-huh.
there was, this position was never
So what my
appointed.
detailed notes say is the statute was passed in 1977, and there's no record of this position ever being appointed or filled.
Yes.
Interesting. Okay. Same with the Cancer Advisory Committee?
Yes.
All right, good bill. Less government.
Sort of red tape rollback.
Yes.
There we go. All righty. Anybody want to, any other questions?
Yes, sir.
All right. Senator Mangum?
Brass has really hit on what I was dealing with, but is there anyone dealing with cancer and the prevention of cancer anywhere in the state of, who does that and why? That's something I'm very interested in. I lost my
Yes.
wife 2 years ago.
I actually have the cancer state plan in my bag over there. I will give it to you. So
Who- what
DPH,
department?
the department leads it, but these positions and the requirements of that committee are not functional and haven't been for many years. We oversee it with federal funds in partnership with Georgia Core and Georgia State University and have work group meetings. They're actually meeting
So
tomorrow.
it's very active.
It is very
Georgia
active.
Core is the
Georgia
main
Core.
organism along with others.
With DPH,
Who
yes.
is Georgia Core?
All right, so why don't we do this offline, and then, all
Okay.
right, anything relating?
She can get you a lot of information
Yes.
about how the state's
There's
dealing with
Bukudos
cancer
of.
right
We
now.
appreciate that.
Thank you.
Yes.
When the time is right, I wanted Senator Orrock to do the motion for red tape rollback for DPH. What do you think?
Oh, Mr. Chairman, I'm at your disposal.
All right, let's do that.
And are we naming this bill in the motion?
Hand over the red tape rollback.
You can call it that. I didn't name the bill, and it is an agency bill, so they probably didn't want anybody's name on it.
You can call it whatever you want,
I
though.
concur with the author of the bill.
Okay, thank you. And second here by Senator Robertson.
Yeah, with Senator Orr.
Okay, there we go. We got it. All right. All those in favor, raise your right hand. Okay, it is unanimous. Thank you very much. Thank you. All right, so we got another update here. Ambulance surprise billing, Senator Still, SB 462. And we had no one to sign up for the red tape rollback bill, but we do have a few. And so Jesse Weatherington, we're going to give you 7 minutes or less. Jesse in the audience? Yes, thank you. And we have, 1, 2, 3, 4, 5, 6, 7. So I'm going to give the other side 15 minutes, and y'all decide on how y'all want to speak, and we're going to keep good time. But right now, the stage is Senator Still and our caucus chair, and he's going to introduce his guest, and the floor is yours, sir.
Thank you, Chairman. Thank you, Committee. Good to see y'all again. It's been a long time, and I don't spend enough time in Senate Health. With me today is Mr. Bud Owens. He is a county commissioner. He is an EMS expert, and he is going to be testifying with me today and helping to answer any technical questions, but I can certainly give you my perspective on the bill first. So, many years ago, as a young college man, I made extra money in the summers working as an EMT. I understand the inside and out of the back of an ambulance, and I understand the stress of transport of someone in a medical emergency and then trying to collect money and get them to sign a contract or a bill of sale when you get them to their destination, usually a hospital, and then trying to collect that on the back end. It's stressful for the patient, it's stressful for the EMT, and it's incredibly difficult by the owner or the finance team of that ambulance company to try to collect on that. This bill seeks to rectify the problem with in-network versus out-of-network on that collection. It defines what that rate maximum will be. And if you know anyone who's had to be transported in a medical emergency, it can sometimes be thousands of dollars. This simplifies that and gets a uniformity to that for all transport companies that do that. It does not get into air. I was asked that earlier today. This is strictly ground. And I think the most important thing to realize in this is this has been a work in progress for years. This has not been something that just popped up. I think we've all been hearing about this since at least the 22 session, if not earlier. I know that some of our friends in the insurance world don't like this because of reimbursement rates, and that's ultimately what this boils down to, and what the committee will need to decide is not to define what the rate is, but do we want consumers to have to deal with surprise billing in that critical emergency time, or if they do have a health plan, should they be able to have a negotiated rate that is reasonable for them to be able to agree to? So with that, I'll walk you through the bill, and then I'll hand it over to Bud. But going on to page 2 of the bill, clean claim, line 21, right? So we're a clean claim for reimbursement of services rendered. Covered service, line 24. An emergency transport service which a covered person is entitled to receive under the terms of their health care plan. Lines 26 through 29 just defines what an emergency transport service is. Line 30 goes to first responder, any firefighter. of a municipal, county, or volunteer, fire department, paramedic, emergency medical technician, which is what I used to be, a peace officer, which Randy used to be and sometimes still is defined in Code Section 35-8-2. Healthcare plan shall consider emergency transport as a covered service when such emergency transport is requested by a first responder or healthcare practitioner. So this is ensuring that we're talking about emergency services. This is not just, anything outside of that. Line 37 is very important. The minimum allowable reimbursement rate under any healthcare plan other than a state healthcare plan for covered service to an out-of-network ambulance provider. Now, questions come up, in-network versus out-of-network. The in-network rates are pretty low. And I will tell you that in my conversations, and I'll certainly let Bud speak to this, but this is really important because a lot of y'all have asked me about this. The negotiated rates with the insurance companies are not one, they would rather just remain surprise billing, because it's not at a sustainable rate for them to be able to make an affordable living. Ambulance companies can't work under some of the low offered rates that they're at. And that gets us to line 45, which is what they're wanting to do is 325% of the reimbursement rate under the Medicare program. So they're already set here on Medicare. It's just saying that for insured rates, it'll be 3.25 times that. There was a bill introduced about 2 weeks ago in the House by Chairman Powell that was at 400. This is a lower amount, and this is something that all of the EMS service providers that are here today have agreed to. It says that they will be paid within 30 days of service. And I've also heard from EMS companies that are in network with some providers that are having to wait 12 months or more to be paid on those rates. So this ensures that they'll be paid in a timely fashion. These aren't large publicly traded companies. These are, for the most part, small, privately owned ambulance services, and having to wait a year or more for their money is really unacceptable. And that pretty much is the bill. Bud, would you like to say a little bit about your background and add to it?
Sure. Today I'm representing ACCG, serving as chair of the Health and Human Services on the Policy Council. And
That mic a little bit closer to you. And Bud, what's your last name and where
Owens.
you from? Owens, and where are you
yes,
from?
I'm actually from Calhoun, Georgia.
Okay.
I serve as Vice President of Mobile Medicine for Georgia and Alabama for Atrium Health. Currently, we are operating EMS services in 13 Georgia counties, and in 8 of those counties, we're providing 911 services. So it really hits home to me. But working as a county commissioner and through the ACCG process of policy recommendations each year, this has been one of the top things that we've discussed for the last 3 years at that level. One of the most critical issues that we have in this industry is reimbursement. Reimbursement has not changed through Medicare in many years. We continue to see insurance companies that are working as hard as they can to not pay the ambulance bills. But it's a service that we have to have in our communities. And we have to have readiness where those ambulances are prepared and ready to respond, whatever that situation might be, because it is typically life or death at that moment. So this is one opportunity that we have seen that we can really improve the reimbursement issue that we're facing. Another part of this bill here, it really addresses the issues that we have with those insurance providers that do pay. They will send the checks instead of to the EMS providers. They will send them directly to the patients. And then the patients have the responsibility to either pay that bill or spend that check on something else. So they will typically go out and spend the check on their own personal needs instead of paying their EMS bills. And that has become a consistent problem. Won't name the insurance companies that are doing that, but we're struggling with some of the larger insurers in doing that as well. This is one step in helping the EMS industry to be able to stay afloat and to provide the services that our citizens expect and need. So we're appealing to you for support in this, and I'm glad to answer any questions that I might be able to answer for you.
Thank you. I do have one question. You were talking about the patient getting the reimbursement whenever it shows up. Is that in the bill anywhere? I don't see it.
I was thinking it was.
The
I understand the
patient
question.
receiving the reimbursement, he was saying.
He's saying in practice,
Right.
for those carriers that are in network with some of
Right.
the insurance
Okay.
companies, that frequently the insurance company will remit payment to their client, not to the person who billed it, therefore making the liability, it would be like if you were
Yeah, I
providing
get it.
patient care, right?
Believe
So
me.
That's what
That's what I want to know.
it's saying that they're going to pay them directly.
It is, that's line 57. I
57
didn't
says they'll
remember
be
that
paid
item.
directly, but
Thank you.
in the question.
Thank you,
all I was
Mr.
asking.
Finance Chair, we're good. All right, any other questions? Senator Orrock.
Thank you, Mr. Chair. Thank you all for bringing this issue to us. What's the meaning of, on page 2, lines 34 through 36, that a healthcare plan shall consider emergency transport service as a covered service when it's requested by a first responder or healthcare practitioner responsible for the care of the individual? There's another whole scenario where somebody determines, they or their loved ones determine that they need to call an ambulance. And is that not covered? Is
Well,
that
the-
type of call to for an ambulance service not
I
honored
presume
by the
a
healthcare
healthcare
plan?
practitioner would include an EMT or paramedic, right?
Yes.
It would also include a 911 dispatcher, and that's where those calls are coming
It
from.
would include a 911 dispatcher.
Yes, ma'am.
How, where do they fall in that definition? Because this language looks like.
Line
it-
33.
Communications officer as defined by.
The definition of the first responder. So,
EMT,
by dialing
peace officer,
911, then there's a communications officer who
Yes, ma'am.
gets the ambulance on the way, and that's considered a covered ambulance run that the health care plan should recognize. Okay.
I don't want to throw a wrench into this, but, I mean, there are calls that ambulances run to, or they have the run for, they go to the patient, and it may be that it may not be indicated, and many times they'll call the ER and say, this patient's stable, it's actually just a doctor's appointment, they need non-emergency transport. That does happen. So just because, but otherwise, I mean, that's what the EMTs are there for.
But increasingly, what doctors' offices say is call 911, go to the emergency room. That's what they say, go to the emergency room.
Absolutely.
Yeah.
And that's indicated. So,
No, well, I
Senator
mean-
Harrell had a question.
Yes, so I had a constituent who contacted me early in the session, and I'm going to describe the situation. You can tell me whether this bill would help. So it was a 59-year-old gentleman who was living with his 24-year-old daughter, and he had symptoms of a stroke. And so she called 911. The ambulance came. He was taken 3 miles to Northside Hospital, was treated for a stroke. And he later received an ambulance bill for like $2,400. He was Anthem, and they said it was out of network.
That's right.
So he had no choice about which ambulance got sent, because I think that's chosen by the county. So he has no choice. How can it be out of network? Can you explain that to me?
Bud, do you want to go first and I'll add color to that?
Oh, you can add color, and then I'll wrap
Okay.
it up. How about that?
So in DeKalb County, it's not just the county, it could be independent providers as well, right? So it's going to be the first one that gets there. If that ambulance service is not in network with the provider, then they're going to have to bill self-pay on that.
But
There's
there's
nothing
no
to-
opportunity for him to call in network or know if the ambulance is in network.
Because
So-
when it's a life and death situation, it's who
Yeah.
gets there first.
So that's what this bill is for.
But will this bill help that?
Yes.
How?
Because it's going to ensure that if he had Anthem, that they're going to be reimbursed, they're going to have to bill, the ambulance service is going to have to bill at that rate. It's going to be a fixed
So
rate
he
for
would get a
everyone.
lower rate? Or
He would
it
have
be
been a
in
much
network?
lower rate. He would have been a much, much lower rate.
Okay.
It would probably would have been half.
So it would still be out of network, but it would be a lower rate? Because it was an
I
emergency?
mean,
Correct.
this is what lines 42 through, 65 are all about. All right.
So this would help him?
Yes.
Okay.
Yes, that's what
100%.
this is
I thought
partly
so,
aimed
that's
for.
why I co-signed it.
Yes, ma'am.
You're good. Senator Kirkpatrick had a question, and then.
Yeah, just on the process of I know a lot about billing as a physician, but I don't know a lot about of how the process works for ambulances. Would you normally be submitting the bill to the patient or to the insurance company?
To the insurance company.
So in an emergency situation, you would get that information later and then submit the claim, or, I mean, how does that work?
We gather that information up front when the patient is transported, and then that, if it's an insurance involved, then we bill directly to the insurance company.
I'm sure there are circumstances where the patient you may not have the insurance information, and I presume you circle back or somebody circles back.
We
on
do.
that.
The bill then goes to
Right.
the patient contacts us to let us know that they
Gotcha.
have insurance.
Gotcha. All right.
I hope that answered that correctly.
Chairman of Finance.
All right, thank you, Mr. Chairman, and great to have Commissioner Owens up here from my Senate district, and we've both worked at Atrium. At times, my last time was New Year's Eve. They don't see much of me anymore. And I was originally worked on surprise billing some years back. We got it passed out after a few years of struggling. We left ambulances out because it was like the one fight I couldn't solve, and I wanted to get a bill out, and I hate that it got left out. But I've seen both sides of this where, insurance companies don't do what they should, but I know other situations in the metro where somebody said, I need $5,000 to take your child to Children's Hospital, which I think is terrible on that side as well. The change in this particular thing, and I'm supportive of this, but the change is that we put in arbitration and all the others, and it was baseball style arbitration that says the arbitrator has to pick a number. So you wanted to pick a number, you wanted your number to get picked. You didn't put something way out here and hope that it came to average. Driving the numbers closer together. The only thing I would say in this, and I don't know if 325% of Medicare is a good rate or not, I have no idea, but we're just specifically setting a rate which is really completely different than what we did in everything else for surprise billing. So I just have no idea if that's a reasonable number or not, I guess.
I believe Indiana is the state that actually set it at 400%, and the other states that have passed this type of billing have established a foundation, a platform for that rate.
Above 325.
Yes.
Okay. He is the champion of surprise billings, no doubt about that.
I don't want to go back to that.
Yeah, I'm sure. That was a long thing. Senator Brass.
So I've got a similar story with a constituent to Senator Harrell. I had a constituent, she went to the hospital, I believe it was attempted suicide, if I remember the story correctly, and then got, was it 1013? Yeah, so she gets 1013, put in an ambulance, and I think brought maybe to Grady or somewhere up here. And she got her, we'll call it surprise bill, and it was $5,200, and from Noonan to the Capitol's just under 40 miles, so it's not a huge distance. But anyway, $5,200. Her insurance covered $400 of it, and so she came out of pocket for $4,800. And I want to make sure I understand the bill correctly. That this bill would require the insurance company to pay not the $400, but either that $5,200 or the 325% of the Medicare rate, which is what? What is the Medicare rate?
Great question. I don't know today.
Okay.
Can I phone a friend?
I'm not the chairman.
Sir? Thank you for letting me speak.
No. Oh, you mind going to the podium, introduce yourself, and tell us that? I'm glad to have an expert in the crowd.
Good afternoon. Thank you, Mr. Chairman. Thank you. I can answer that. So the American...
And you're...
I'm sorry, Terrence Ramatar with the Georgia Ambulance Providers Association, also the American Ambulance Association. We're doing a lot of work with CMS. CMS produced a study to show what the costs are for EMS across the country, and they did it geographically. So so their reimbursement rates, which are right now about 22 years old, are less than a third of the cost. And that's why you're seeing across the states people, these states landing at about 325 to 350, because that's really covering where the cost is. So the trade-off is you can't balance bill to patients,
Okay.
but you're getting your cost covered.
So do you have a rough estimate of what his scenario would be? 40 miles, attempted suicide?
So I'm assuming that's a BLS rate. So if it was a Medicare patient and we were strictly Medicare, now understand these are discount programs, that's not the cost, right? The Medicare rate for that is about $300 and roughly, don't quote, about $388
So about
plus
$400
mileage.
then. I got
So
you.
if you do 3.25 to that, that's where you end up at the cost around the state. So we were very strategic on where that number is and worked with DOI to make sure we're covering costs, not too much higher. It really can't go that much lower because we're below cost. Thank you.
So we have a AI-generated number, if you'd like that. It's pretty close to what he's saying.
So I get, or a follow-up.
Yes, please.
278.
Okay.
A follow-up, I guess. So what if, so let's say it got to, I don't know, $2,500 is 325%. So would she still be on the hook for the difference of that $2,500 and $5,200 that she was charged? I mean, I know it's going to be much better than $400, what she was responsible for,
The
but.
patient would still be responsible for their copays or.
But the insurance company would be.
But I'm saying for the difference, if that 325 is less than the rate, than the bill, would the patient still be responsible for the remaining balance?
It's the lesser, and it's A or B is or.
Right.
So it's the or. Be the lesser.
So if they had the deductible.
Yeah, so that 325 could be less than the bill.
Right.
So then are they still on the hook for the remaining balance?
So line number 52, any copayment, coinsurance, or deductible paid for covered service provided by an out-of-network ambulance provider shall not exceed the amount of a copayment, coinsurance, or deductible amount owed for similar service provided by an ambulance provider that belongs to the provider network in a healthcare plan.
So then, in that case, a follow-up, if you allow. So in that case, if there was a delta there, then the provider, the ambulance provider, eats the rest, essentially?
That's
Okay.
correct.
And they've got
All
the
right,
negotiated rate.
that's fair. Okay, I just want to make sure I understand. Thanks.
All right.
Good question.
Before we circle back to Senator Orrock, anybody else with questions? We're going back to Senator Orrock. All right.
Thank you, Mr. Chair. I have a question about how the whole system works, because you'll often see 3 emergency vehicles showing up at a home that's called in saying there's a heart attack patient here. Pick anything, stroke, whatever. Explain the economics of that people, entities seem to be competing with each other to run to this thing? And then I have one more question after that.
The 911 system really prohibits that. They have the designated EMS provider for that residence or that location, and that is the one that is dispatched. You may see a fire department vehicle there as well, because in the 911 system, that closest appropriate vehicle that is a first responder would be dispatched first in a critical life-saving situation. So you may have a fire department or some type of fire department vehicle on scene before the actual transport ambulance arrives, because they may have been closer. So that's simply to try to save the life, to get care to them closer, quicker.
Get a medically competent person that can respond.
But the charges don't happen, and they happen only with the service that is transporting the patient.
Okay. A second question, and that is that there's a Grady ambulance service very near my home, and I'm not far from Grady Hospital. Are they in any of these entities that are promoting this bill?
Do we have anyone from Grady here? Okay.
So they're part of the. I wanted to be sure of that. Because I've gotten good information from them in the past on this type of issue.
Very good.
They're the best.
All right.
All right. Okay, so let's have some testimony. Mr. Owens, you signed up, so I presume you have testified, and
I'm good.
You're good. So, Mr. Weatherington, you want to go first or last?
Chairman's discretion, sir.
Come on, Jesse, come on down. Mr. Weatherington, GAHP, is that right?
Yes, Mr. Chairman.
You
I
can,
have a document I'd like to,
that'd be great. Thank you.
where would you like me to go, Chairman?
Podium, please, sir. Mr. Weatherington has been around Capitol for quite some time. He was with DCH a long time ago, if I remember correctly.
Yes, sir, way back when.
Way back when.
Again, I'm Jesse Wethington. I'm the president of the Georgia Association of Health Plans. It's been a couple of years since I've been in front of the Senate Health and Human Services Committee, but glad to be back here today. We would like to give the committee some things for consideration in regards to this bill. As health plans, we do have a concern, really, and I'll limit my comments to very narrow ones. I don't think I'll go close to my 7 minutes, Mr. Chairman. Our concern is that statutory rate of 325% of Medicare may be a bit too high to strike an appropriate balance. As Senator Huffstetler remarks are very well taken, I came to this role kind of at the tail end of the conclusion of the negotiations on the surprise billing Consumer Protection Act, which was adopted by the General Assembly several years ago. And of course, emergency medical services were left out of that process as relating to ambulance transportation. But there was a treatment both of non-emergency medical services kind of after you get off the ambulance, and then a separate treatment for non-emergency medical services that you had the ability to shop for in advance or schedule, things of that nature. And the approach that was ultimately taken by the General Assembly in that code section for non-emergency medical services was a little bit different than the one that you see here. And the reason that was adopted was this concern that if the government sort of picked a number, if it was too low, there was an incentive for the insurance industry not to try to negotiate and get providers in network. And if it was too high, kind of the countervailing position applied, and there would be a strong incentive for the providers to not contract and just sort of take this statutory network that was fixed, be on their way. The patient was taken out of the middle, so to speak. And I do think that is a big benefit of the bill you see in front of you. This is the prohibition on balanced billing. So at least that patient, is not getting caught with a huge sum after they've had this transport. And again, emergency medical services, ground ambulance transportation is a very different medical service than kind of anything else you see. You don't have the ability to shop. The network is a little bit less of an issue. It's very different in urban areas versus rural areas in terms of the number of providers that you have. So I would submit to you, it's our contention that the 325 is a little bit high. We do think that would sort of err on the side of a bias towards not contracting, and we would ask for consideration of a lower amount, or alternatively a treatment similar to the existing Surprise Billing and Consumer Protection Act, where one of these sort of payment prongs referenced a median in-network rate for contracted providers that currently exists in the code elsewhere. Beyond that, I would submit for your consideration a development that is so brand new, we are just getting around to dealing with it ourselves. That's the piece of paper we just had distributed to the members of the committee. Like very many other things, there's a lot of surprises coming down from Washington, D.C. these days. And this, I think, would fall squarely within that category. For those of you that are in the insurance or healthcare world, you may be familiar with something known as the Annual Notice of Benefit and Payment Parameters. That's published annually by the Centers for Medicare and Medicaid Services and an office called CCIO, which regulates the healthcare plans that are covered under the Affordable Care Act and those that are sold on exchanges like Georgia Access, formerly called healthcare.gov until a couple of years ago here. There's a longstanding provision in the Affordable Care Act related to something known as Essential Health Benefits Package, or the Minimum Essential Health Benefits Package, which drew a floor under what a health plan had to cover to be considered a qualified health plan under the exchange. Traditionally, there has been this provision related to state-mandated benefits where the law and then CMS had sort of set a date and time where whatever your state's essential health benefit package was would be sort of snapshotted at a date. That date was December 31st, 2011. And then that would be sort of what was covered by the federal government through the premium tax credits that flow through exchanges to customers who buy their insurance on the individual market through the exchange to make those plans more affordable. This rule has traditionally not been enforced, but in the NBPP for 2027 that was published on Monday in the Federal Register, It's buried in the middle of a 144-page document. They have announced that they will no longer allow state mandated benefits to receive these premium tax credits, and that the state itself would be responsible for covering the cost of any mandates that exceed whatever that essential health benefits package was as it stood December 31st, 2011. So this is a monumental change, the far-reaching consequences kind of beyond what's in this bill before you. But we wanted to make the committee aware of this. I shared this with the sponsor earlier in the day. He and I agreed that this was probably good for the committee to consider. But I think there's a strong indication, at least initially, that at least the cost of this as related to individuals who purchase their coverage through the exchange would be borne by the state treasury. And the way that that defrayal works is the cost of coverage over that essential benefits floor is either remitted from the treasury to the health plan or to the insured for the cost of that coverage. So I wanted to have the committee be aware of that concern as you're considering this legislation. But really our association's position is that we would like for the enumerated amount to be something closer to what the contracted rates are, so there's not a strong bias towards not contracting. So thank you, Mr. Chairman. If there's any questions, I'll be happy to take.
Question here.
Two things. The first one, I think, just to make sure I'm right, the federal surprise billing, which was done after Georgia's, didn't cover ambulances either, did it?
I believe that's correct.
But the other question along those lines is, I know we could not regulate ERISA plans. So would this legislation not apply to ERISA plans?
I don't believe so. You'd have to look at the definition of health plan in 3320E, but I believe that there is an exemption in the definition section in 3320E, if I'm not mistaken.
So how many plans would it not cover in that case, would you guess?
The state-regulated small group market, traditionally we thought 9 to 10% of the covered lives. That's shifted a little bit as we've had more individuals get their coverage on the exchange, but it's a smaller slice of the market.
But the bigger employer type plans are the ones under ERISA, or is that,
Yes, sir.
that correct? I'm trying to remember this stuff, yeah.
That's probably 65-70% of the covered lives in the general
Okay.
market.
So I think it's a good thing, but I do have concerns, that we're still gonna have people getting surprise bills. I don't wanna go out there and say nobody's getting it because of the ERISA plan, so that's just making sure we're all aware of that. That was my only questions. Thank you, Mr. Chairman.
Okay. Vice Chair?
Sorry, one more question. From the standpoint of how the bills are looked at, I would imagine that they're submitted as the base rate plus mileage. And is that all included in the Medicare rate? So in other words, this bill, it says 325% of the Medicare rate. Would that include the mileage also?
I believe that's correct. I'm no means an expert on EMS billing. I know there's like the levels of life support. There's modifiers for if you're in a rural, urban, or super rural area, and I think that there is a mileage aspect that's added to the claim, but I'm not at all sure if that's universal.
I'm getting a bunch of nods in the audience. Thank you. Any other questions? All right.
Do we have any idea what kind of cost, like a guess, fiscal impact for this, for the state benefit plan?
The particular to this bill, the state plans are excluded in the definition healthcare plan that's in the front.
Right, I
part
get
of this
that. So
bill.
you're saying the state would have to, through appropriations, I assume, pick up the extra?
I understand your question. So there's not, the state health plans aren't covered in this bill in terms of like somebody who's enrolled in Medicaid or the SHBP. The related piece about what we'll be on the hook for next year potentially, we're just getting around, we've just realized this was even a thing, so I would need some time to get back to you on a cost estimate ballpark for it.
Okay, just curious. I'm sure it'll come up at some point.
Any other questions? Thank you, Ms. Weatherden.
Thank you, Mr. Chairman.
Appreciate it. Well, go ahead and start with those in favor. I can't read some of these names. I got Tim Kibler down, and Thomas, I don't know. What do you say?
Thomas.
It's Thomas somebody.
Thomas McGinty.
Okay.
How did I do it? Is that
All right, Thomas, somebody with American Pro Health, Ameri Pro Health. Nobody, there we go. All righty. And then Tim Kibler's in the chute, and then Chad Black, Jeff Adams, Sam Polk, and Terrence Ramutar. All right, just if everybody wouldn't mind telling us who you're with,
Sure.
name, and so forth.
Thank you, Mr. Chairman. Thank you, committee. Thomas McEntee, I'm with AmeriPro Health, which is we're an ambulance service provider here in Georgia. We provide ambulance services to 11 rural counties in Georgia. We're part of the GAPA Association as well as the American Ambulance Association, and we're speaking in support of this effort, of this bill. A number of states around the country are engaged in similar efforts to sort of put some rationality around this and establish a reasonable ceiling that protects the consumer, first of all, the patient, and then also protects the ambulance service providers. Ambulance service providers are made up of a patchwork of many different types of providers, some commercial, some municipal. And the structure of this bill really addresses sort of what's the best case scenario for everyone. And the fact that emergency services were omitted from other efforts on surprise medical billing is because there's just a different level of complexity. And so for the people that we serve here in the state of Georgia, we support this bill and ask that you approve it. Thank you. Any questions?
All right, any questions? No questions. Thank you, sir.
Yep.
There we go.
Thank you, Mr. Chairman. Tim Kibler with the Georgia Alliance Community Hospitals. We're Georgia's not-for-profit hospitals. Rise in support of Senator Still's bill. I think you're going to hear more from the ambulance folks that probably have more to share with you than I do. So in consideration of time, I'll yield back whatever else I may have, unless there are any questions.
Thank you. Also, Chad Black, Jeff Adams next, and then Sam Polk, Terrence Ramutar, who's already up here.
Thank you, Mr. Chairman. My name is Chad Black, and I'm the chairman for the Georgia Emergency Medical Service Association and also serve as Governmental Affairs Director for Metro Atlanta Ambulance. We are in support of Senate Bill 462, and GEMSA, our organization, we represent all the providers and the services in the state of Georgia, private, government, and hospital-based providers. As you know, when someone calls, and it's been talked about, when someone calls 911 on one of their worst days, and the 911 agency responsible for that zone, we don't get to choose if they're in network. We simply respond and transport. It's that simple. We don't do the wallet biopsy on scene, as we call it. When we go to the doctor, they'll come in and say, here's what you're responsible for, here's what the insurance will pay, sign this form. So we simply bill the insurance company, and overwhelmingly 90% of those or more in the state of Georgia are classified as out of network. So that puts the patient with a balanced bill. And we were kept out of surprise billing. It would have been catastrophic if we had not have been. That would have left 159 counties and roughly 170 911 zone providers, increasing the taxes on the citizens, the taxpayers, and the constituents in those counties to offset what reimbursement doesn't cover. Our reimbursements from Medicare, Medicaid, and insurance doesn't even cover the preparedness cost of buying the ambulance, equipping it, training the people, salaries, benefits, and much less cover the cost when we actually respond on a call and have to transport. That is up, and you'll hear some where 50% of their budget is paid by reimbursement, the other 50% is covered by the taxpayers on a tax that is assessed to them. Some places it's higher. If we go into surprise billing, which we are told we're going to have to, and we agree with that, and we don't have a fair reimbursement floor, that is going to increase the taxes in almost all 159 counties on the 911 zones to offset what we're not able to balance bill. So, this will help keep EMS solvent.
Okay,
hopeful.
I appreciate that. You know, I've sort of limited y'all's time. You're filibustering
Sure.
here. Are you able to address what Mr. Weatherington said?
On which one?
All right, I guess you're not. All right, so if you don't mind, if I could get Mr. Ramator back up here. Mr. Ramator?
Good afternoon, Mr. Chairman, committee
Yes, sir.
members.
Introduce yourself again, and I really would like for you to address what Mr. Weatherington said. Thank you.
Yes, Terrence Ramatar with Georgia Ambulance Providers Association, the American Ambulance Association. Here we're all, again, representing ambulance services across the state. We're obviously in support of this. 17 states have passed this legislation almost verbatim. You'll see that rate pretty uniform across. I think I explained how the science behind that rate is to make sure that we're covering costs. And before I address that, one other thing I want to mention that's fairly new in terms of an anecdote, and this happens all the time. This happened last week in DeKalb County. Ambulance service responds. This gentleman had a GI bleed for 3 days, and he noticed it. It was mild. And the gentleman is now in the bathroom 3 days later, and there's blood. It's just a mess. This gentleman is now in kidney failure. And what happened was when the family and the provider said, "How long did you notice this was a problem?" He said, 3-4 days. And they said, "Well, why are you calling now?" He goes, "I don't want to get a bill." So this is solving so much. To address, I know Mr. Weatherington said a lot, but to address what portion of that?
Do you have this?
From the printout from the Federal Register that came out yesterday, I don't have that. I will tell you that I do familiar with some other states. On the Essential Health Benefit Plan, the Affordable Care Act actually did define EMS as part of the Essential Health Benefit Plan to be reimbursed. It didn't go on to say reimbursed in full. So we're closing a loophole here. I'm familiar with some states that there's a dollar amount that triggers that mandate. I am not an expert at that, but I will tell you that EMS is less than 1% of the expenditures, and so rarely do we, in this sector of healthcare, we're so small, we typically don't get triggered into these types of things. So that's the best I can answer to that.
I have a question for him.
Sure.
I thought of something that we've done in some previous bills. Whenever we've tied anything to Medicare, and we did this in our contracting when I was in practice, we would tie it to a specific year of Medicare, because Medicare doesn't always go up. And in the medical world, it frequently goes down. So I don't know if you'd entertain tying it to a specific year.
I can answer that. So Medicare has, and why we like this rate in the ambulance world is there's an ambulance inflation factor that's assessed every year on the Medicare rate. So it does keep up with inflation. Every once in a while, it does go backwards, but every year it's typically around 1 to 3%. Of an increase. So it does keep up with inflation. It hasn't been rebased in 20 years, or 25 years actually. However, there's an inflation factor that adjusts every year.
So you're not worried about if it were to go down rather than up?
No, it's just simply a matter of inflation, right? So there's a formula involved in that, and it's fair. So
Thank you.
if prices do
Appreciate
go down, so will that.
So you're saying from a surprise billing standpoint from the ACA, then it allows the state to take precedent in this situation related
Yes.
to ambulances?
As a matter of fact, in the No Surprises Act in 2019, established the Ground Ambulance Patient Billing Advisory Committee. That was a national committee with health insurers, providers, citizens, and they actually published recommendations that went back to Congress on how to fill the gap for balanced billing for ambulance services. This bill, along with the other 17 states, is reflective of the federal recommendations.
So the state's recommendations take precedent over the federal and the ACA?
That's, so in the federal No Surprises Act,
I got you.
allows the states to come up with their solutions.
Is the committee clear on this? Okay. All right, Senator Cowser.
Well, thank you, Mr. Chairman. I'm just curious why we're going 325% of Medicare reimbursement rate.
Yeah, so we've been working with CMS for 25 years to update the base rates. I did mention before there was a cost study. There is a process. The federal government does work. They're currently in a multi-year process that evaluates the rates. So we're finally getting looked at. It may be a couple of years if MedPAC does get to it. But right now, the study that was published, CMS did a cost study nationwide, published a study about costs, and the costs are roughly about a third, and that's how we end up at the 325. Someone talked about finding that fair balance between keeping the ambulance service sustainable, but also making sure that it's not too high and keeping a ceiling. So that's why that 325 or 350 you're seeing in multiple states, because the CMS Medicare rate is about a third of the cost.
But you would get a higher rate if they had private insurance.
So we're talking about commercial out-of-network, right? So these out-of-network commercial bills, the way this bill is structured, they either pay the county rate, and if there's not one, they pay the lesser of two, either the bill charges or 325% of the Medicare rate. So for commercial plans that are out-of-network, I apologize, sorry.
I was wondering, why not just either the billed rate or the in-network rate?
Go ahead.
That would be a lot lower than 3 times Medicare.
All right, Senator Steele.
The in-network rate for many of the insurance companies is either, if you take the Medicare rate of a baseline, some of them are at 75% of the Medicare rate, and on the high end, maybe only 125% that. So it's only about a 25% plus or minus on either side of the Medicare rate, which is already significantly lower. If we run the math models of some of the examples that we've already heard, this 325 times Medicare rate is still about half of what the self-pay out-of-network amount is.
But that's the negotiated rate between the insurance company and the ambulance services. How can they
And that's
complain
why,
about that?
well, that's why 90% of them don't take the in-network rate, because it's so low. They'd rather pursue the self-pay out-of-network.
Thank you.
And that's why there's surprise billing, apparently 90% of the time. Any questions for our federal partner? Clarification there. All right. Thank you. If you don't mind
Yep. Thank you.
sitting
Appreciate your
down, I
support.
sort of gave a little bit more time there. Still have Jeff Adams and Sam Polk. I think we probably got 2 minutes and 45 seconds. And I cut off somebody, Mr. Black, if you'd like to get back up there. All right, so got about 2.5 minutes. Y'all want to do it together or separate or whatever you want to do?
Good afternoon, Senators. I'm Sam Polk. I'm the Assistant Chief in charge of EMS operations for Henry County Fire Rescue, as well as the Chair for the Region 4 EMS Advisory Council and Vice Chair for the Georgia EMS Association. Senate Bill 462 ensures reliable reimbursement that's going to offset the burden on my taxpayers in my county. We have increasingly more expensive costs to operate. We balance in Henry County how much we charge against what's in the best interest of our taxpayers as well as our patients. In 2025, if this bill had been in place, we would have received an additional $1.9 million in revenue. However, with that, we would not have billed patients for that same amount during that time or turned over to collections. But this reduces the burden on our taxpayers, so we don't have to raise any additional taxes to fund the provision of our care. As mentioned before, we have the same issues with commercial insurances that don't actually pay us. They pay the patient, even though we sent the bill. This adds stress to our patients, the insured, as well as stresses our ability to actually collect. Our citizens deserve to be cared for economically and physically responsibly. They deserve that we provide those services in an efficient and timely manner. This bill is not the final solution in addressing the ongoing needs for EMS in Georgia, but it is a crucial step in the right direction. Any questions?
Thank you. I didn't like there any questions, so we got less than a minute. Mr. Polk.
I could do mine that fast.
All righty.
My name is Jeff Adams. I'm the Fire Chief and EMS Director for Habersham County. I'm also a member of the Region 2 EMS Advisory Council and a GEMSA board member. And I just want to give you the scenario that I have that I'm working with in Habersham County. I've got a population of about 50,000 people. A current budget of about $5.3 million. We're going through that lovely process now. Revenued, so they take that $5.3 million and they project what is going to be collected by the billing of the patients, which is about, like Mr. Black said earlier, 50%. So along with what Sam was saying, if we can get this bill in place, it's going to reduce the burden on those taxpayers. EMS is expensive. Ambulances cost $350,000, $400,000 a piece. The staff, the training, the salary and benefits of these people, it's expensive. The cost per day to put for the EMS services in my county is about $14,500 a day. About $3,000 per med unit. We were dispatched on 8,600 calls last year. We transported 5,000, okay? And as Mr. Owen said earlier, we only get paid for those we transport. Leaving a cost of transport of about $682. So this bill is important. It's important we all get on the same page. We got to take care of the taxpayers. We got to look out for them. Thank you.
All right. I think that's it for testimony. Thank you so much. Got those names reversed. Mr. Polk and Mr. Adams, thank you. Any further questions from the committee? All right, Senator Lucas.
With this bill, are we saying we got a rate? And that's the rate that's going to be paid in the state on EMS services?
For those with health plans, yes, Senator.
Well, I know y'all want to get your money. But what I'm saying is this would be a rate set statewide that they will have to pay.
It is a statewide, but it doesn't apply to everyone.
Well, who is it that they would not apply to out of network?
No, this addresses out of network.
This is for people that don't have any insurance of any kind. Like if they're not on the Affordable Care Act, they don't have a market plan or anything, then they would have to self-pay, just like they're self-paying for their health care now. But if they have a health plan,
this would be the rate.
yes, sir. And Medicare.
I just want to make sure when we do it, that we are saying what the rate is. If you have insurance, this is what you are going to be paid, and not have folks coming back saying, "Well, we need to raise it."
If they're on Medicaid, they've got a rate. If they're on Medicare, they've got a rate. If they have insurance, this sets that rate.
All right, that's what I want to make sure.
Yes, sir.
Thanks for clarification. Appreciate it. Any other questions? Be happy to entertain a motion here. Motion. We'll recognize the former deputy sheriff here, Senator Chairman Robertson, second by the chairman of rules, the powerful rules chairman. And any further discussion? All those in favor, raise your right hand. That looks unanimous. All righty. Thank you very much. We appreciate that. It is a good bill. Meeting next Monday. Meeting adjourned. What's that? Oh. Meeting next Monday. Meeting next Wednesday. Yeah, that's right, because we're not here on Monday. We're not here Monday. All right. Meeting